Good morning, everybody. So, welcome to today's pediatric surgery and medicine combined round. So, today we'll discuss a infant who had come with an acute history of abdominal pain and distension. So, we'll see the approach to this case, the approach to intestinal obstruction, and how to manage it. So, Dr. Raneta will be presenting on the pediatric medicine side.
Good morning all. Today we'll be talking about the pediatric surgery and medicine rounds. Our objectives of this clinical presentation are recognition of the intestinal obstruction in ER to differentiate between small and large bowel obstruction clinically, and immediate stabilization of the patient and investigations. We have a baby P who is 10-month-old female who came from Jalandhar, Punjab, with presenting complaints of abdominal distension, who presented on 31st 12 with abdomen distension for 5 days, did not pass stools for 5 days, and bilious vomiting for 2 days. This is the picture of the child taken with consent. Antenatally, it was a booked and supervised case with natal history term LSCS in view of breech presentation. The child cried immediately after birth with a birth weight of 2.5 kg. And a meconium was passed at 24 hours of life. This is a second born to a non-consanguineously married couple with the elder sibling, 5 years of age, alive and healthy, and no other significant family history. In the past history, nothing is significant, but no history of any altered bowel habits in the personal history. And immunized, the child was immunized according to the national immunization schedule. The child arrived on 31st. The child was taken to a local hospital on day 1 of his symptoms and was admitted there for 3 days. The child, in view of respiratory distress, was started on nasal prong oxygen, and in view of suspected sepsis and abdominal distension, was started on IV antibiotics, and it was referred to and the child was referred to PGI, and these were the basic investigations which were done in PGI in the outside hospital, which showed anemia and leukocytosis. So initial assessment at triage, which showed airway which was open and stable, breathing, the child was tachypnic with increased efforts. The circulation showed a mildly prolonged CFT and poor peripheral pulses, with BP being normal, and disability. The child was okay, and the child was afebrile with sunken eyes and dry mouth. Which we came to a conclusion in the ER of respiratory distress with compensated shock, which required level 1 resuscitation. The examination, the child had a flat AF of 1 centimeter, and the child was lethargic. Abdomen was distended, and sunken eyes and dry mouth, and no other obvious dysmorphism. Weight, the child was 7.4 kg, length was 68 centimeters, and head circumference was 42 centimeter. These were the systemic examination, with respiratory system showing tachypnea on examination and decreased air entry in the basal area, and per abdominal examination showing a grossly distended abdomen with umbilicus being stretched and visible veins present. And palpation of the abdomen showed visible abdominal distension. Tenderness were not there, however, and oral hernial orifices were normal, and bowel sounds appear to be sluggish. So this is a database of the patient, which is a 10-month-old female with progressive abdominal distension and constipation for 5 days, with bilious vomiting for 2 days. On examination, the child was tachypnic with abdominal distended, bowel sounds sluggish, and decreased bilateral air entry. So initial, our provisional diagnosis was intestinal obstruction with some dehydration or paralytic ileus or septic ileus. So the stabilization which was done in ER was, the child came with respiratory distress, so we started on nasal prongs oxygen, circulation, which we had given a bolus of NS, and dehydration correction, 5% dehydration correction plus maintenance IV fluids were started, and started on IV antibiotics, Piptaz and Cipro Piptaz. The child was kept NPO with CRTA and strict IO charting was maintained. The investigations in PGI was the child had hypoalbuminemia here, and sepsis markers were elevated. The electrolytes were relatively normal in this child, and HB showed anemia with leukocytosis was seen in hemogram, and blood transfusion was received for this HB of 8.7. PT and INR had mild derangement, and the culture was sterile, both pus and blood. The pH was alkalotic. The last pH showed respiratory alkalosis in this child, and these were the investigations which was done in PGI. We have it showed multiple air fluid levels, and CT showed gross abdominal bowel loop distended, and USD showed dilated fluid-filled small loops measuring about 2.5 centimeters in diameter, showing sluggish peristalsis with mild interloop fluid seen. I would like to call upon my radiologist counterpart, SR, Dr. Harsimran, for radiological.
Good morning, everyone. So I'll be presenting the radiology part. So we were provided with axial contrast enhanced CT sections, which was done outside. So these are the axial sections. We just have the thick sections which are available on the film. So the CCT was done after administration of oral contrast, where we could see that the stomach was distended with oral contrast. The visualized part of the liver on the visualized sections appeared normal in attenuation and enhancement. The kidneys and the pancreas and the aorta also appeared normal. Going to the lower down sections, we could see that there were multiple air fluid levels with dilatation of the small bowel. Most of the small bowel, predominantly the small bowel loops were distended with fluid. The oral contrast was only seen opacifying the stomach and few of the proximal jejunal loops. On the inferior sections, we could see that there was this abrupt transition point, which was seen in the right hemipelvis, with a segment of the small bowel, likely the distal ileum, showing symmetrical circumferential mural thickening with preserved mural stratification. We could see mucosal enhancement. Going to the further sections lower down, what we can see is that the oral contrast did not pass beyond the proximal jejunal loops, as we can see that the small bowel loops distally were only fluid filled and they were grossly dilated. Air fluid levels were also seen. The large bowel loops were consistently collapsed. This is the descending colon. Going to the further inferior sections, we could see that there was mild free fluid in the pelvis. The lower down sections of the pelvis showing that there was ascites. So these are the X-rays which were done in PGI. So this is the supine abdominal X-ray of the abdomen, which showed that there were few dilated small bowel loops which were seen in the central abdomen. However, most of the abdomen was gasless, and even the rectal gas was absent in the supine abdominal X-ray. The lateral decubitus view showed that there were multiple air fluid levels which were predominantly seen in the central abdomen. The rectal gas was again absent in this. So an overall approach to large versus small bowel obstruction on an X-ray must be considered. While a large bowel obstruction is peripheral with presence of horstrations, in small bowel obstruction, the dilated loops are mostly central. The jejunum show characteristically presence of alveoli conjuventus, which are circumferentially thickened loops, circumferential complete mucosal folds, which are characteristic of a dilated jejunal loop. The ileal loops are featureless, as we could see in the CT sections. And a small bowel obstruction is also characterized by absence of gas in the colon. So going by the X-rays which were done outside PGI and inside PGI, along with the available CT sections, a final diagnosis of a small bowel obstruction with transition point in the distal ileum secondary to an infective or an inflammatory etiology was kept. Thank you.
So coming to intestinal obstruction discussion part, intestinal obstruction is divided into dynamic and adynamic obstruction, where dynamic means the peristalsis is present, which and adynamic means peristalsis being absent. It is further divided into extrinsic, mural and intramural, paralytic, and adynamic is divided into paralytic ileus. Extrinsic main causes are adhesions, hernias, tumors, abscess, volvulus. And intramural, the main causes are inflammation like tuberculosis and Crohn's disease, malignancy, intussusception and atresia. And intraluminal causes are fecal impaction, meconium ileus and foreign body, and parasitic obstruction of ball of worms. So this was a study which was done from the Department of Pediatrics in Sayaji Rao Medical College, which showed in Gujarat, which showed that the congenital causes majority are developmental anomalies like imperforate anus, Hirschsprung's disease, and Meckel's diverticulum, followed by ileal or jejunal atresia and hypertrophic pyloric stenosis. And acquired causes, the most common are intussusception, abdominal TB, and a gangrenous appendicitis. So this shows the age-wise distribution for when a child comes based on age, how to classify, like what are the most common causes in these children. We have intussusception, primary peritonitis, and Hirschsprung's disease being three most common causes in age group of 1 to 12 months. In 1 to 5 years, the most common causes are ascaris lumbricoids, obstructed hernia, and bands. Hence, very important in examining all the hernial orifices. And more than 5 years, it is the most common is enteric perforation, abdominal tuberculosis being most common. The pathophysiology of intestinal obstruction. It is whenever there is a closed loop obstruction, there is progressive bowel distension, which will cause raise in the intraluminal pressure, which in turn increases the intramural pressure. There will be increase in wall tension more than venous pressure, which will decrease the capillary perfusion, thereby resulting in ischemia and other inflammatory peroxidation by lipids by activating the ROS, and thereby there will be inflammatory mediators. Causing SIRS and shock ultimately, and this ischemia will further cause necrosis and perforation. In this stasis, there can be bacterial proliferation, which can cause endotoxin release, damage the barrier function, and there will be translocation of the bacterial toxin, again further worsening the sepsis and features of MODS. So the diagnosis is basically clinical with history, physical examination, and investigations playing an important role. History, it's pain, constipation, and vomiting and abdominal distension. The pain is usually colicky paroxysms of pain, normally seen, but however, if there is strangulation, the child will be more toxic looking with constant pain. The general physical examination, it is important to observe the vitals, urine input-output monitoring, the child's general appearance, whether the child is toxic or non-toxic, and check for signs of dehydration, as these patients are more prone to go into shock. And systemic examination to check for any previous scars, any previous surgery, or any hernial operation was done or not. Palpate to check for tenderness or guarding, and auscultate for bowel sounds. So another important thing is to differentiate between a large and a small bowel obstruction clinically, which based on pain, which is usually absent in small bowel obstruction. The child will come with vomiting, which is early and copious, with abdominal distension being relatively less there. But however, if you think about CHPS, you will have a mass localized to that area. In small bowel obstruction, the pain is more evident, with vomiting presenting much later and abdominal distension present, which was there in our index case. And large bowel obstruction, the child will have pain abdomen and vomiting presenting very late, and abdominal distension is also present in them. So our management will include laboratory findings and radiological evaluation. In investigations, we have to do a complete hemogram, RFT, LFT, electrolytes, and blood gas analysis. Blood gas analysis will give us an idea of where the bowel obstruction is. If it is a upper small bowel obstruction, Mostly the child will come with vomiting, hypokalemia, hypochloremia, and metabolic alkalosis. But however much, if it is in the lower down the small intestine, the child will come, but the intestinal fluid is more of a bicarbonate rich fluid, thereby losses will resulting in metabolic alkalosis, and large intestinal will come with hyperammonemia features of with respiratory alkalosis, alkalotic presentation in the child. So radiological finding, we have plain X-rays, USG and CT being our main primary 3 investigation of choice. We have a plain X-rays, which supine is preferred more than erect because it helps us localize the obstruction site. And features on plain X-ray, as ma'am said, we have jejunum, which is mostly the dilated bowel loops are present centrally present with full with whole. There will be the valvae conjunctivis, which is very significantly seen, which is present throughout the bowel. Throughout the bowel loops, and there will be lesser air fluid levels and valvae conjunctivis. Then there is in ileum, it will be centrally placed dilated loops, more of air fluid levels, and it will be characteristically characterless. And large bowel, they will have peripherally placed bowel loops with haustral folds. USG will help us in determining the fluid in the peritoneal cavity. It helps us estimate the caliber of the bowel loop and peristaltic movement. A CT scan is useful, especially to figure out signs of ischemia. It will give us whether it's a complete obstruction or not, and determining the location and cause. There will be decreased bowel wall enhancement, mesenteric edema, and intestinal wall thickness, and pneumatosis intestinalis and portal vein gas. So this is the picture which was explained earlier. These are the red flag signs which you have to keep in mind when seeing a child in ER. When the child is having constant pain, tenderness with rigidity, fever, tachypnea, leukocytosis, shock, closed loop on radiographic findings, and signs of ischemia on CT, the child will warrant an emergency surgery. This is the approach, the management approach to intestinal obstruction. Whenever you suspect a bowel obstruction, keep in mind airway A, B, C, D, E, and insert 2 large IV cannulas. Keep the child NPO. Insert a large NG tube, and give supportive care for the child in terms of analgesia, antiemetics, antibiotics if there are features of perforation or strangulation. And urgent surgery consult has to be given. If the patient is stable, you can go for an abdominal X-ray and bedside USG. And if the patient is stable, you can go for a CT abdomen and pelvis. And later, definitive treatment management would be surgical management. So this was a course in PGI. The child presented on 31st, that is the first day itself. The child underwent, was kept NPO with CRTA with some dehydration correction in triage. And the child was started on injection piptaz in triage, and the child was operated on the same day, on 31st by 3 p.m. The child was in OT, and started on injection Miro and metronidazole post surgery. The child was allowed orally on day 9 of staying in PGI, and later discharged on day 12 to day 13 of the stay. So our queries to the surgical team would be when to initiate feeds in such children, when to follow up after discharge, and what are the long-term outcomes and complications in such children, and what is the team's experience in handling such cases.